you so much, Dr. Mawela, and thank you to Amanda and thank you to Abby for sponsoring this.
Yes.
Dr. Mawela did mention our helplines. I did put a link in the chat. You can click on that, it'll open up a poster for our Right to Care helplines. You're welcome to phone us. And we aim to try and help people who are busy with patients. While you're busy with your patients, you can get an answer straight away. We don't always know all the answers, so sometimes we have to go and consult with somebody else, but we try as far as possible to be able to help you out while you're busy with your patients. So please feel free to make use of that helpline. If you've got any questions on basically anything, HIV, there's a TB helpline as well, pediatric HIV. We also deal a lot with adults and treatment failure as well. So you're welcome to phone with any queries that you have. So thank you so much. So I've been asked to talk about the management of common conditions in pediatric HIV, and this talk I've been giving since I think 2008, and it's changed unbelievably. And what has changed about it is the fact that we have changed the way we treat children with HIV. So whereas before we were waiting until they got sick.
Dr. Leon, your audio is a bit fading. If you can try and
the mic a bit.
Okay, thanks.
Is that better now?
Yes, continue and then I will let you know. Thanks.
Okay. All right. So things have changed. And why have they changed? In that we have changed the way we treat children with HIV. Whereas before we would wait until they got sick or the CD4 counts dropped before we started treating them. Now we're treating them literally on diagnosis, which sometimes can be as early as at birth. And does it sound better, Stefan?
It was better initially, then it faded again.
Yeah. Now?
Yes, if you could keep it like that,
all right.
yes.
All right. Okay. So things have changed in that we're treating these children much earlier. And so a lot of these conditions we're not seeing as commonly as we did before. But the problem is that we are still seeing them. So it's all very well to say, you know what, we don't need to know about these things because all of a sudden these things will crop up and we won't know what we're looking at. So it's important to go through these things, even though a lot of them we aren't seeing as commonly as before, which is a good thing. It's fantastic that we're treating children with HIV and managing them so they don't actually get sound problem.
Yes, I'm not sure if your mic is mobile. Maybe hold it by the hand.
No, it's not mobile. Maybe try the computer mic. Is that better now?
Yes. Maybe closer to the screen.
All right. Just tell me if it's getting worse again, then I'll have to find another solution. The other thing I can try is try get on my phone. That's another option, and use that as a mic. But let me know how it's going.
Yeah, it's good now. Sure.
All right. Okay. There are my disclosures. So there are two main patterns of disease that we see in children with HIV. There's actually three, but two main ones. Okay, and the two main ones are rapid progressor, slow progressor, and what they call a long-term non-progressor. Now, a lot of these are academic because children should not be progressing, and we should be treating them long before they progress. But as I said, they do sometimes slip through the cracks. So the rapid progressors are these children who get sick very early on in life with proper opportunistic infections. For example, pneumocystis, CMV. They will often have brain involvement, HIV encephalopathy, often marked failure to thrive. These are the kind of children that we used to see in the cover of Time magazine many years ago. That emaciated, marasmic, really sick children, often stiff because of their HIV encephalopathy. And without any treatment, they would die by the age of 2 years of age. Now, the slow progressors are somewhere between them, the rapid progressors, and adult patients. You know, adult patients don't get sick at all for 10 years, and then they suddenly start to get sick. So slow progressors are not like that. They do get sick, even in the first year of life. But it's relatively minor things like sinus infections, pneumonia, otitis media, that kind of thing. And they usually grow well, although they may be short. And I've always used to maintain in the old days, you wanted to screen out a class of kids for HIV, just line them up in terms of height and test your 5 shortest kids, and you've got a good chance of picking them up in your slow progressors. And like in the rapid progressors, they do have characteristic disease manifestations. And without treatment, they would survive 5 to 6 years without treatment. Although I did have one child who got to the age of 17 before his CD4 count dropped low enough to need treatment. So they can sometimes take a long time before they need treatment. And it's important to appreciate which pattern they fit into in terms of trying to determine what is actually wrong with this child, because they've got typical characteristic disease manifestations. So the common conditions that we're going to see in children, yeah.
Maybe try joining with your phone. I think that, yeah, sure.
Because normally
colleagues, just a few seconds, and then we should be okay. Thanks.
Yeah. In children with HIV, it can be more severe, and you can see both of these children have got really severe seborrheic dermatitis, and you can see the typical greasy, waxy kind of scale that you're seeing there. It's different from atopic eczema, atopic dermatitis, where you get red patches on the cheeks and the elbows and behind the knees. It's a scaly kind of a rash, and often you can see very, very dry skin. And the thing about seborrheic dermatitis is that it's actually very interesting, an allergy against a normal commensal fungus in the skin. So this is a fungus that doesn't cause disease even in people with HIV, but what you get is an allergy against this fungus, and that manifests with the seborrheic dermatitis. And so to treat it, the first thing you want to do is obviously tackle the dryness of the skin, and the dermatologists all recommend using UE, or angemulsificans, or the English translation would be emulsifying ointment. Now there's not aqueous cream, which is UEA, it's just UE, and it works very well. But the problem is that the clinics will give you a little tub, sort of, I don't know if you can see, this big, which lasts them exactly 1 day. So you need to get a big 500-gram tub, and the way they use it is to use it as a soap, and then straight after the bath, you quickly towel them dry, and then you smear them with the same ointment. Smear them so much that when you lift them up, they slip out of your arms. Then you know you've put enough on. And what that does is traps the moisture inside. And the dermatologists use that for all causes of dry skin. It works very well. What the pharmaceutical companies do is add 1 or 2 little ingredients and then charge 10 times the price. But basically the active ingredient is the UE. So emulsifying ointment for the dryness, and then because it's an allergy against the steroid, you could use topical steroids or topical antifungals. If it's just in the scalp, you can use an antifungal shampoo, but because it's not a baby shampoo, you just got to mind the baby's eyes. We have had some anecdotal evidence that in severe cases, oral griseofulvin works, but I must say we're not seeing those kind of cases anymore because we've got ARVs around. The Surfer, how's the sound? Is it better?
It's perfect. Thanks, Doc. Like beyond perfect. Thanks.
All right, good. Okay, yeah, it was just that one setting that it slipped to the wrong setting. Okay, candidiasis. Well, we all know about candidiasis, but let me start with a little poll and see if you know about oral candidiasis. How many different types of oral candidiasis are there? Oral thrush. How many different types are there? And you've got a choice of 1, 2, 3, 4, or 5.
Should we give it up to 30 seconds or?
Yeah, we can give it a few more because I see people are getting very active.
All right.
Okay.
Great.
Almost at 30. Okay, good. All right, I'll do the polls. Okay, so to share with you now, so I see most people said 3, and then 2, and then 1, and then only a few, 23 people got it right. In fact, there are 4 types of oral candidiasis. So let's have a look at that. Okay, the 4 types are pseudomembranous, erythematous, median rhomboid glossitis, and angular cheilitis. Let's look at our pseudomembranous. Apologize for this terrible picture. It's an adult, but this is the typical cream cheese that we all know very well, the pseudomembranous candidiasis. The next one would be the erythematous, which is just a red patch on the palate. You can see it there quite nicely. Then your median rhomboid glossitis, you can see the nice rhomboid shape on a coated tongue. You don't need to know your geometry to know that's a rhomboid. Okay, and the last one, the angular cheilitis, this sores at the corners of the mouth. So that's the 4 types of oral candidiasis that we get. Sorry, I see there was a question about the reason oral ciprofloxacin is not used in children. Just to let you know, it's because in beagle puppies, dogs, one species of dogs, it causes arthropathy, sore joints. But it doesn't seem to be a major problem in children. I certainly wouldn't use it in every patient with otitis media, but if you tried everything else and it's not working, then you certainly can use ciprofloxacin. Okay, so the 4 types of oral candidiasis: the pseudomembranous, erythematous, median rhomboid glossitis, and your angular cheilitis. Okay, now what about Candida nappy rash, thrush nappy rash? So to understand Candida nappy rash, you need to understand the normal nappy rash that we get, which you call ammoniacal nappy rash. All right, why is it called ammoniacal nappy rash? Because it's caused by ammonia. Where does ammonia come from? Now, a lot of people always say it comes from the urine, but unless you're a hamster, we don't have ammonia in the urine. Hamsters do have ammonia in the urine, but humans have urea, which is NH3, and ammonia is NH4. Right, so what converts the urea to ammonia? Bacteria. Where do bacteria come from? They come from, what else is sitting in the nappy? You've got the urine. What else is often sitting in the nappy that's got bacteria in it? Of course, the stool. So if you've got stool and urine mixed together, sitting in the nappy for a period of time, the bacteria in the stool will act on the urea in the urine and convert it to ammonia, and then that ammonia causes a contact dermatitis. Right. So because it's a contact dermatitis, and most babies flex their hips, so the ammonia doesn't get into the creases. And so you get sparing of the creases with ammoniacal dermatitis. But with thrush or Candida nappy rash, you can see it goes right into the creases. And in addition, you get the very characteristic satellite lesions. These ones on the side there are more typical, just next to the actual main rash. These ones that are higher up is not really so typical. But just next to the rash, you see little branching out little buds of rash. I suppose that should remind us of the branching out buds of the yeast. But so the satellite lesions and the fact that it goes into the creases tells us that this is Candida nappy rash. Right, now in terms of management, so the oral Candida, we all have nystatin available at our clinics, but we all know it doesn't work. So why doesn't the nystatin work? Because you put it on the nystatin and it just runs off. So it doesn't sit around long enough to treat the Candida. So if you are going to use nystatin, what you need to do is use it at least 6 hourly, and even 4 hourly is better if you can. And when the baby goes to sleep, the last thing that must touch the oral mucosa must be the nystatin. So they mustn't get a nystatin and then give them a bottle, because that's going to just wash down the nystatin. And if you do that, often it does work. The Dactar oral gel works much better because the gel makes it stick, and then you don't have that problem, but it's much, much more expensive. And then if you're really struggling, especially with severe oral Candida, you could try fluconazole. In terms of treating the nappy rash, well, here nystatin is fine. You can just use a nystatin cream. And the problem is that we all know that Candida nappy rash keeps on coming back. Why does it come back? Because the gut is colonized with the Candida fungus, okay? And every time the baby has a dirty nappy, well, gets back into the nappy area. So in this situation, not only must you treat with nystatin, and I'll usually put a barrier cream, zinc and castor oil on top of that, but also give them oral nystatin. And here you want the nystatin because you want it to run, not to stick in the mouth, but to go all the way down to the bottom. So you give them oral nystatin, which sterilizes the gut, and then you don't get recurrences of their candidiasis. Okay, let's talk about pneumonia. Very common in children with HIV. I remember I was in private practice, I probably diagnosed 5 to 10 children with HIV whose only manifestation was they presented with a pneumonia, no other signs or symptoms. So it's a very common presenting sign, especially in older children. And it may be relatively straightforward, or as you can see, this child has got a bilateral pneumonia. It's also got a bit of an effusion on the side here as well. And the management of pneumonia in children, first of all, is to make sure you're not dealing with TB. Because 10% of acute pneumonias will be TB. Depends on which studies you read, between 8 and 18%. But and I'm not talking about with the typical, months of losing weight and coughing. The child presents with a 3-day history, high fevers, looks like an acute bacterial pneumonia. 10% of those will be TB. So you want to make sure that you rule out TB and treat for TB, obviously, when you make a diagnosis. Also, in babies where you would suspect they've got pneumocystis, you would want to cover for pneumocystis until proven otherwise. We'll talk about that when we discuss PCP. And you want to take into account the local resistance patterns and the child's recent antibiotic history. So that Thoracic Society has come up with new guidelines recently, where they say you want to consider CMV in children less than 6 months of hypoxemia, and I will talk about that when we talk about pneumocystis. And also they're pushing really amoxiclavulinate augmentin for most of the pneumonias that we are going to encounter. So similar to as you would with any other child, but just take into account the child's antibiotic history and also your local resistance patterns. Right, what about gastroenteritis? So yes, there are specific opportunistic causes of gastroenteritis. You can see 2 of them on the screen here, but for the vast majority of the children we're going to see are going to be presenting with a normal, common childhood gastroenteritis, which tends to be generally in the winter viruses and in the summer bacteria, and things like rotavirus. People will say, but we immunize against rotavirus, but remember that the rotavirus immunization only protects against severe disease in HIV negative children, but it doesn't stop them from getting rotavirus. And your management will be as with any diarrhea. You want to make sure that the child doesn't dehydrate, and if you've got any infectious cause, you want to treat that. Now, in the old days, we used to use something called Bowie's regimen. It was named after Professor Bowie, who was the Prof Emeritus of Paediatric Gastroenterology at Cape Town University. And he proposed this combination of gentamicin, cholestyramine, and metronidazole. I think he later dropped the metronidazole, but I must say I found it very useful and I continue with it. And the motivation behind this really weird sounding combination, remember that gentamicin here is oral, it's not intravenous, and please don't give this dose intravenously because it would be 10 times the normal intravenous dose. So it's oral, and the reason why it's oral is because it doesn't get absorbed systemically, it only acts in the gut. So the motivation behind this was that there was a postulation that chronic diarrhea would normally what happens is that 2 things happen. First of all, you've got your villi, and what happens is that any attack on the gut will reduce the villi, flatten the villi, and so you end up with especially lactose intolerance, because remember the enzyme that breaks down milk, which is lactase, sits right at the tip of the villus. Okay, so any little insult to the gut is going to destroy that, and so they can get a temporary lactose intolerance. So the first thing you would do is take them off lactose containing milk unless they're breastfeeding. If they're breastfeeding, then the benefit of continued breastfeeding far exceeds that of taking them off the lactose, and so you wouldn't do that. But if they're on a formula milk, take them off lactose just for about a week. Remember, it takes about 3 days for the gut to recover. So you do it for a week, and by that time things are sorted out. Okay, but then if that doesn't work, then you would try this Bowie's regimen. And what happens is that you get bacterial overgrowth in the gut with chronic diarrhea and the bacterial overgrowth, what it does is it unconjugates the conjugated bowel salts. And unconjugated bowel salts are toxic to the intestinal mucosa. So what you do is, to treat it, you would give them gentamicin orally, which kills off the bacterial overgrowth. And then cholestyramine would bind those toxic unconjugated bowel salts. And then you added metronidazole for parasites, especially Giardia lamblia, which is a duodenal parasite, which doesn't usually get down to the stool, and so it's very difficult to make a diagnosis. As I say, he later dropped the metronidazole, but I kept it on because obviously in children with HIV, it's something that we would worry about. And it's quite a complicated way to give it, because you've got to give the gentamicin six times a day, 4 hourly. The cholestyramine you've got to give 6 hourly, and the metronidazole you've got to give 8 hourly. And in addition, you can't give anything together with the cholestyramine because it will bind all those other agents, so they're not going to work. So what we used to do is just admit them for the first 3 days, because you can't expect a mother to give something 4 hourly, something 6 hourly, something 8 hourly, and they mustn't be given together. And the nurses were very competent at doing that. And then once they'd finished the course of gentamicin, then they could go home and finish the rest at home. And I must say it's very effective. If you've got a child with chronic diarrhea, that's certainly something that is worth trying. So Cryptosporidium is also a intestinal parasite. There you can see them, it's at the top picture, and you can see that it's actually identified by using a modified acid fast stain, and you would see the Cryptosporidium in the stool. And in patients who are immunocompetent, Cryptosporidium is a self-limiting disease. It's a self-limiting disease. It gets better on its own. But let me tell you, we had an outbreak a few years ago when I was in private practice, and we had these kids, and yes, it does get better, but they literally poured and poured and poured for 10 to 14 days. And then they got better on their own. But if someone's got HIV, if they're not on ARVs, you literally will not get rid of this. Okay, you actually need to get them onto antiretrovirals, and there's some evidence that PIs have some efficacy against the Cryptosporidium. But while you're waiting for the ARVs to work, there is some pretty good anecdotal evidence that you can use azithromycin. Okay, it's a different dose of what we use normally. It would be 10 per day on day 1, and then 5 per day for the next 9 days, so 10 days in total. And I must say, in our outbreak, we used it, and it did make a major difference in those children. So it's worthwhile trying. If you've got a child with Cryptosporidium, while you're waiting for the ARVs to take an effect, it's worthwhile trying azithromycin. Okay, next thing I want to talk about is warts. And this is a child who I treated many, many years ago. He's an adult now. And you might ask, where are the warts? Well, if I describe to you, the dark skin is his normal skin. And everything else are what we call plain warts. Okay, he's just literally covered from top to toe with these warts. And they're coalesced together. And very, very difficult to treat. And also we get a condition called the Kubner phenomenon. I don't know if you've heard of that. That's where a condition will line up in a scratch, and you'll get a linear manifestation of that skin condition. So let's do another poll quickly. Which of the following conditions can cause the Kubner phenomenon? I know the dermatologists love the Kubner phenomenon. They love to ask us which of these conditions can cause it. I must say, I don't know all the answers here because I'm not a dermatologist, but I know that they do love asking these questions. Oh, there we go. Share the results. All right, so it looks like people felt molluscum contagiosum, psoriasis, it seems like. Not so many plain warts. So from an HIV point of view, the most common two that would do it would be molluscum and your plain warts. Okay, lichen nitidus we don't see much, and lichen planus we don't see much, but those would be the main ones that we would focus on, would be the molluscum contagiosum and the plain warts. Okay, so here let me just show you an example of the Kuppner phenomenon. That you can see it's not the same patient I showed you earlier. You can see how these warts have lined themselves up in a scratch, and you get a linear line of the warts. Molluscum can do the same thing as well. All right, so how do we manage patients with warts? And I must tell you, I really struggle, because, I mean, yes, you can use pedophyllin in adolescents with genital warts. So we also see genital warts as well. And just to let you know that if you do see genital warts in a child, it's not necessarily a sign of child abuse. Obviously, you need to ask very sensitive questions, but children can pick up the human papillomavirus in the birth canal when they're born, and it can manifest. So it sort of remains in the mucosa, manifests many years later as genital warts. So don't, arrest the parents, but of course you do need to ask very sensitive questions. So the management, pedophyllin, if you can get hold of it, you can use in patients with genital warts and teenagers with genital warts. The two cauteries, electrocautery and cryocautery, are painful. Okay, they cause a lot of pain, and there's no ways you could cauterize that patient that I showed you that was covered in warts. I mean, you give him 3rd-degree burns. Surgery, I've had a patient with genital warts, and I think 6 or 7 ops before we got rid of all the warts that she had. Imiquimod, Eldara is available in the private sector. It works by sensitizing the immune system against the human papillomavirus. So immediately you can see a problem, because the patient's got no immune system, it's not going to work. So if you are going to use Imiquimod, then rather first get the immunity up with antiretrovirals, and then you could try the Imiquimod. And then ARVs, when I've got that patient that I've showed you many years ago, I asked the experts overseas, how should I manage this patient? And they said, don't even worry about the warts. Put the patient onto ARVs and you'll see they will just melt. Okay, 20 years later, they're still there. But I have had some patients we put onto ARVs and the warts just disappeared. So it's worthwhile trying, but I wouldn't rely on it. Okay, the next condition I want to discuss looks like warts, but it's different. It's also caused by a virus, but it's not a human papillomavirus. It's a pox virus, and it's typically seen in this area of the face. And this is how it looks. Normally, in the textbooks, they describe this one like you're seeing over here, where you've got a tiny little dot in the middle, little belly button. So they call it umbilification. So it's got a little umbilicus. But mostly we just see it as these papules, very typically in this face. They used to always say that there's a cheesy material that comes out. Not all of them have that. And they always told us, when you want to treat it, you've got to squeeze out the cheesy material and take a orange stick. Don't ask me what an orange stick is, and dip it into phenol, and then put it into a little gap, at the little hole that's left from squeezing out the cheesy material. But as I say, most of them don't have cheesy material. I wouldn't know what an orange stick is, so we don't use that treatment anymore. But they're usually relatively mild. If you're a very sensitive viewer, please don't look at the next slide, because it's a more extensive case. Okay, I warned you. Those of you who are gasping now, I asked you not to look. Okay, so that's a child with obviously extensive molluscum around the eyes. So the modalities for treatment they give are virtually the same as you would use for warts, but it's a very different disease. Now, remember, these are common childhood conditions. All children get these conditions. And one of my sons actually got molluscum when he was a youngster, about 18 months of age. And we went to a dermatologist, and she said, you know what, I can burn them off. It's going to be painful, or we can leave it and it will be gone within 18 months. And let me tell you, 18 months to the day, they disappeared. We got a few successive crops, but literally 18 months to the day, they were gone. And that's the thing about molluscum. Molluscum will get better without treatment. Either if the immunity is good, it's going to get better on its own. And if the immunity is bad, it melts away on ARVs. It literally melts away on ARVs. Within 3 months, they're gone. So unless the molluscum is worrying the child, for example, that child I showed you with the eyes were covered. Okay, definitely that child needs treatment. But if it's not worrying the child, you can just leave them. It's an HIV positive child. You put them ARVs, it will disappear on its own. But obviously, if it's worrying the child, then you would need to do something about it. Okay, here's a nice, easy poll for you about shingles or zoster. Shingles represents a secondary manifestation of which primary disease? You'll see in my talk, we'll be talking about a lot of primary, secondary, and children obviously will normally get primary. So which condition? And I see you've all got it, so I'm not even going to waste time. Okay, so yes, you're quite right, varicella. So chickenpox, what happens is chickenpox is the primary disease because they don't have immunity against the varicella zoster virus, so it involves the whole body. And then when the patient recovers, the virus retreats to the dorsal nerve root ganglion, where it remains there for many years, waiting for the immune system to drop, okay, for the immunity to drop, and then it will come out. But because it's sitting in the dorsal nerve root ganglion, it will infect that nerve and just go along that nerve, and that's why you will get zoster shingles just along the root of that nerve, and it's usually only on the one side, usually only one nerve involved. Okay, do you see it in anybody with who's immunocompromised? But also, interestingly enough, you get it. It's a normal manifestation in adolescence. And I think it sounds like my family is a case study, but my brother, when he was a teenager, and there's nothing wrong with him, and he's alive and well, and he should live a long, long life, but he got zoster when he was a teenager, and it's just a normal adolescent manifestation. Okay, good. So the thing is, here you can see a patient with zoster. In children with HIV, they may get it just along one nerve root distribution, but it may be more extensive. You can see a patient's got quite a few nerve root and a bit of necrosis there as well. So it can be more extensive in children with HIV. Okay, the treatment for zoster in pediatrics, unfortunately, we don't have all these other fancy antivirals that we have in adults, and so we are stuck with acyclovir, and you give it either intravenously or orally. Okay, so this condition is first cousin to zoster, and you can see the lesions in the mouth, and we all know this condition. This is the primary manifestation, and we're more familiar with the secondary manifestation. And this is, someone did mention earlier, okay, herpes simplex virus. Herpes simplex virus gives you what we call a herpes gingivostomatitis. It's a common pediatric normal childhood condition that we see in children. And once again, because it's a primary disease, they don't have immunity against the HSV. And so they get these ulcers all over the mouth. Okay, they get a high temperature, they're really sick. The mouth is so sore, they're drooling all the time, and they don't want to drink, so they often dehydrate. So I remember I admitted quite a few kids just for a drip because they were just not drinking because of the stomatitis. Okay, and then when they get over this, okay, it hangs around and will come back as a fever blister, and that's a secondary manifestation. So the primary manifestation is this herpes gingivostomatitis, really sick child, okay, but the fever blister secondary manifestation usually occurs when the immunity is a little bit low, okay, but it doesn't have to be that low. Often you may even see it in when a woman is menstruating, they can get it, and any other people will often get herpes, the secondary herpes simplex, the fever blisters, and we're quite familiar with that. But in children with HIV, you may see more extensive, you may have recurrent stomatitis. They may not go onto the fever blister, but they have recurrent stomatitis. Or as you can see, this child, he's got it on the lips, he's got it above the lips, and he's got it on his nose. So more extensive. This is what you call, on the right, is called a herpetic whitlow. The child who's got stomatitis, who sucked his finger and then got it on his finger. And remember, I don't know if there are any dentists in the audience, but this is a common condition we see in dentists who don't wear gloves. Okay, the patient's got a fever blister, they're working in the mouth, and they can pick it up and get it on their finger. Herpetic whitlow. And once again, the treatment would be the acyclovir. All right, this is also a common childhood condition, tinea capitis or ringworm, and very common in all children, but more extensive and severe in children with HIV. Shame this child, unfortunately, passed away. I treated her for many years, and then she left me and went to someone else and continued to be non-adherent there, and unfortunately she passed away there. But I used to know when she was not taking her ARVs, because she came in looking like this. Whenever she was on ARVs, her skin was beautiful. When she wasn't taking her ARVs, she looked like this with extensive tinea capitis. As I say, it's a common childhood condition, but if I showed you this, not of the best photograph, which is an abscess, scalp abscess, draining a little bit of pus there. Okay, we all think, send this to the surgeons, but in fact, this is what they call a carry-on, which is also another form of tinea capitis. So if you've got a child who's got a bit of a scalp abscess there, try an antibiotic for a week or so, and if it's not doing anything, then you can send a swab off or just put them onto antifungals. You often will have a good result. Now, in terms of management, yes, we know, we've got these antifungals or Whitfield ointment, if people are still using it. They will work with tinea that is anywhere else in the body except in the scalp, because the skin of the scalp is so thick that the cream does not penetrate right through the layers of the skin, and so you don't get a result. And so you would want to use an oral antifungal. In the old days, we used to use griseofulvin, which is really well tolerated, very cheap. But now we've had problems with griseofulvin not being available. I think it's still available in private, but in the DOH, it's not available. So now we're using oral fluconazole, which is literally like using a cannon to kill an ant. Okay, you don't really need to use fluconazole, but that's all we have. For many years, it hadn't been documented that it was efficacious, but now there is some work to show that it does work, but it's really completely unnecessary, and griseofulvin should be your first port of call. But as I say, if it's not available, you can use fluconazole. And in private sector, terbinafine, which is quite expensive, but it's a much shorter course of treatment. Okay, so those are the common childhood conditions which we see not only in children who don't have HIV, but also in children with HIV, and obviously can be more severe, more difficult to treat, and sometimes atypical. And now I want to focus on a few of the true opportunistic conditions. I'm just taking a few selected ones. Let's start with pneumocystis. Okay, here, let's do a little poll here. Okay, let me just tell you, the polls are completely anonymous. And I just want to get an idea, just to let you know that, let me launch it. There we go. I did have pneumocystis infection when I was a baby. I just want to know who else had pneumocystis infection when they were a baby. If you don't know, you can answer, I'm not sure, but you're welcome to answer. It's completely anonymous. Nobody knows. So I did have it, and Leseg, I think you had it as well, if I remember correctly.
I'm not sure. I'm sure my mother just called it the pneumonia.
No. Okay, I didn't say pneumocystis disease. I said infection.
Oh,
end the poll there. Okay, good. Let's end the poll and let's share the results. Okay, so there are either very few honest people, or there are very few people who actually know that they had it. We all had it, okay? I didn't say disease, I said infection. We all had pneumocystis infection, okay? It's a very common commensal in the environment, and every child picks it up. When do they pick it up? Between 3 and 6 months of age. So children between 3 and 6 months of age pick it up. They don't even get sick from it. They don't even get sick from it. They get pneumocystis infection, and it doesn't cause disease, but they develop immunity, and that immunity is literally lifelong unless something should happen along the way. For example, the patient gets HIV, the immune system drops, and then when the immune system drops, they would then get secondary pneumocystis. But the children who are getting primary pneumocystis infection around 3 and 6 months of age. But if we have a look, okay, and this is a typical pneumonia, okay, it's a very hazy interstitial kind of pneumonia. You can actually even get a normal X-ray with pneumocystis. And if we have a look, when do children with HIV get pneumocystis disease? So we spoke about infection, the primary infection, but when do children with HIV get disease? This is from the United States, but it's exactly the same in South Africa. You can see when do they get their pneumocystis disease, and it's between where? 3 and 6 months of age. So what is that telling us? That when all their friends are getting pneumocystis infection and not getting sick from it, okay, children with HIV are getting pneumocystis disease. So they get primary pneumocystis disease. Unlike the adults we spoke about, get secondary. They've had immunity their whole life long. When the immunity drops with HIV below 200, then they'll become liable, prone to get pneumocystis disease, and they will get secondary pneumocystis disease. But in children, it's primary. And when is it? Between 3 and 6 months of age. You could say, look, at the risk is elevated till about a year of age. So what would be a red flag for us to say this child has got possible pneumocystis disease would be the age of the child, specifically 3 and 6 months, between 3 and 6 months of age, but we can extend it up to a year of age. So any child under a year who is huffing and puffing, you want to consider pneumocystis and cover them for pneumocystis until you have ruled it out. Okay, so here you can see I put together a little table looking at the two types of pneumocystis. We used to call it pneumocystis carinii. They now changed the name to pneumocystis jirovecii, but us old timers still call it PCP. And you could justify by saying it's pneumocystis pneumonia. Okay, so the C used to stand for carinii, but now we say it stands for cystis. So we're still getting away with calling it PCP. But the youngsters out there, well, I suppose we'll call it PJP. Okay, so primary PCP, we say between 3 and 6 months of age, up to a year. Secondary would be over a year, okay? In primary PCP, it's going to be any CD4 count because they've shown that no CD4 count predicts primary pneumocystis. Whereas in secondary, we said it's when they had immunity and the immunity drops later on. They develop immunity against pneumocystis, immunity drops later on, and then they become susceptible. So it would be a low CD4 in an older child below 200 and in younger children below 15%. Now, primary disease, often it's the first manifestation of HIV. So they're well-nourished and often don't have other signs of HIV, don't have lymph nodes or thrush. They may have, for sure they may have. But I remember the typical pneumocystis child we used to see was a lovely, big, 4-month-old chubby baby who's just huffing and puffing, battling to breathe. Obviously, a secondary disease, they often have other signs of HIV because the CD4 count is low. They may be wasted, other stigmata of HIV as well. How they present, as I mentioned, tachypnea, recession, respiratory distress, there may be cyanose, but when you auscultate the lungs, usually very little to hear on auscultation. And one of the lab investigations, which I actually find to be quite useful, is an LDH. The LDH is not specific, so there are many causes of a high LDH. But if the LDH is not raised, you can practically say this is not pneumocystis. So if you get a child, things look like bronchiolitis, but the huffing and puffing, and you're not so sure that the child's 4 months of age, you're not sure if this is bronchiolitis or pneumocystis, you do an LDH and it's 300, you can stop the pneumocystis treatment or don't give it, depending on how quick your lab is. But if it's 1,000 or 2,000, then you would definitely want to cover. But so it's not specific, but it's a very useful for telling us when not to treat them, or usually what you do is treat them and then stop the treatment if you get an LDH spec that's only slightly raised or normal. Okay, so the management of pneumocystis, I didn't read, there was a question in the chat. I didn't read it properly, but just to just tell you about management of pneumocystis is very, very problematic. Okay, pneumocystis disease, okay, in the best of, well, I'm saying no. If you just treat them as a pneumocystis, okay, we know that high dose cotrimoxazole works. So yet if you just give them high-dose chlorpromazine, you're looking at probably a 50% mortality rate. Half of them are going to die. Okay, and the reason why they die is because I said earlier that any CD4 count will predict for pneumocystis. Any CD4 count will predict for pneumocystis, but once they get their pneumocystis, it just knocks their immunity. It just knocks their immunity completely. And once they've got it, then the CD4 count drops right down, and they become a sitting duck for any infection. And they do get many infections. One of the commonest ones they get will be CMV. CMV is very common in children with pneumocystis disease. And it's, in fact, they've shown in a study or two, they've shown that in children who die from pneumocystis, 100% will have CMV infection, 100%. So much so that many years ago, the Red Cross ICU at Red Cross Children's Hospital decided they're going to take this into their own hands. Why? Because they knew about CMV, and what they were doing is they would do the bloods for the CMV. By the time they got the results of the CMV serology they were doing in those days, okay, the child was dead. So what they decided to do is any child who came into the ICU with pneumocystis, they put them onto ganciclovir and only stopped it when they got a negative result. And what happened to the mortality rate? Dropped right down. Okay. Unfortunately, not every ICU has got the resources to put every single child onto ganciclovir, but the labs are better. The lab testing is better. We don't use serology anymore. We'd use a viral test, a PCR, or I prefer the viral load, a pneumocystis viral load. And some of the labs can give you a result very quickly. And then for sure, you put them onto CMV treatment and then stop it as soon as you get a negative result. There's also some evidence, or good evidence, that if they're hypoxic, that systemic steroids will work. Prednisone, 2 milligrams per kilogram per day, and usually go on for about 3 weeks. But if they've got CMV, then steroids would be contraindicated. So another reason, even if you haven't got ganciclovir, another reason to check for CMV is to obviously make sure that if you can give steroids or not. Okay, the alternatives are not as effective as cotrimoxazole, but usually high-dose cotrimoxazole does the trick. But together with that, in addition to CMV, they often will get bacterial infection. And I mean, I had one child who unfortunately passed away, and I put this child onto, I remember clearly, I put this child onto third generation cephalosporin. I think it was ceftriaxone, if I remember correctly. And unfortunately, the child passed away. And the day after the child died, we got back the tracheal aspirate result, which was Pseudomonas and was resistant to ceftriaxone, which I thought was a broad spectrum antibiotic, but you obviously need to cover for gram negatives as well. So quite complicated to treat these children, but not just covering for pneumocystis, covering for other things as well, for gram-negative infections and CMV to rule out as well. Ideally, start them with ganciclovir and stop it when you get a negative result. Okay, and then in terms of prophylaxis, well, in the old days, these children needed to go into lifelong prophylaxis, but these days, and our present guidelines at the moment are saying continue until 5 years of age and then stop it. I think that's probably a bit of overkill. I think with ARVs, if you can get them, certainly you want them at least for a year of age, because we said CD4 count is non-predictive. And after a year of age, I think, if the child is doing well with a good CD4 count, you probably could stop the prophylaxis as you would with anybody else after a year of age when the CD4 count is above 15 or 20%. Okay. I see there was a question about using Whitfield's ointment in tinea capitis. Remember I said it's good for tinea anywhere in the body, but not on the scalp. Once it's on the scalp, the cream doesn't penetrate the scalp, and then you need to use oral antifungals. All right, and we can just talk about it. We spoke about about maybe the diagnosis. And I see there's a question. It's a bit if maybe people could type the questions in the Q&A, to be easier than putting them in the chat. Then I can check them as we go along. So this question: if the CMV viral load is 3,500, would you and they've got confirmed pneumocystis, would you cover with ganciclovir or no? So that's a low viral load. That's why I like the viral loads. Above 10,000, I would cover, but 3,500, I wouldn't cover them with ganciclovir. But thanks, it's a great question. Okay, right, then the next thing, very important, is TB, tuberculosis, very common, and obviously this is a no-brainer. You can see this in a nice, this consolidation and a nice cavity in the right upper lobe. This is an adolescent, one of my adolescent patients with tuberculosis. But if I just show you this picture and tell you this is a child with confirmed TB, not so straightforward, right? Once again, we're getting into our primary, secondary. So adults are secondary TB, children are primary TB. And in children, all you can see, there's a slightly widened mediastinum here. And because remember the GON focus and the GON complex, which we never see a GON focus. The only time you ever see a GON focus is in your final pediatric OSCE, that they show you a picture from 1942 of this massive GON focus that you've never seen before in your life and never will see before. But the lymph nodes we do see, and remember it's closed, so because it's closed, it's not open to the airway, so they're not coughing up bacilli, difficult to diagnose, and primary disease is much more difficult to diagnose than in adults. Okay. And we see the whole gamut of disease with TB. You can see here there's a child with TB of the spine. Not so easy to see on the plain film, but on the CT scan, you can see there it's all being eaten away. And here you can see this is the same patient. And interesting enough, this child had no neurology, and TB spine, they're supposed to have a gibbous, had no gibbous. Okay, it was picked up accidentally. But that's all TB there, eating away the spine. And we see the commonest cause of extrapulmonary TB would be your lymphadenitis, and you can see this child has got draining sinuses, which is called scrofuloderma. We see all of these things. There's tuberculoma. You can see a ring-enhancing lesion with several edema around it. And just, I'm not going to, we can obviously talk for hours and hours on TB, but we follow standard TB protocols. They say that in children with HIV, you may need more than 6 months to treat them, even for uncomplicated TB. But if you do need to treat them for more than 6 months, ask yourself 2 questions. Is this TB? And number 2, is this not perhaps resistant TB? Okay, because there are many things in HIV that look like TB that aren't TB. And obviously, if it's not responding and it is TB, could it maybe be that the TB is resistant? Okay. As we know, if the child is not yet on ARVs, you would ideally want to delay starting ARVs to prevent iris. Okay, and in children, in adults, they've got this thing of, you know, if the CD4 is below 50, then you would treat before 2 weeks. If it's more than 50, you wait 2 months. That's based on adult data. There's no data in children. So generally, what we do if the CD4 is on the low side, we would start 2 weeks. If it's not so, CD4 is reasonable, we would wait 4 weeks. Remember, efavirenz, not that we use much anymore, you don't have to adjust. But lopinavir, if the child is on the lopinavir solution or the pellets, you want to add in extra ritonavir. Okay, ritonavir powder, you would add in to the lopinavir solution or the lopinavir pellets. If they are taking the lopinavir tablets, and remember that lopinavir tablets have to be swallowed whole, then you can double the dose as we do in adults. And also remember, with dolutegravir, you give an extra dose. The adults are getting 50 milligrams of dolutegravir once a day. You add an extra dose of dolutegravir approximately 12 hours after that initial dose every day because of the TB treatment. Okay, Next, we're going to talk about MAC, Mycobacterium avium intracellulare, and I'm just going to introduce it with a poll. And I want to ask you, which of these patients do you think would be at risk of disseminated Mycobacterium avium complex disease? So which of these would be at risk of a disseminated disease? You've got to think this is not an easy one. I'll read it out for you. A 2-year-old with a CD4 of 8%, a 12-year-old with a CD4 of 30 cells per microliter. Remember, in children under 5, we talk about the percentage. Over 5, we talk about the absolute count. A 34-year-old with CD4 of 300 cells per microliter. A number D would be a 4-year-old with a CD4 of 32%. Okay, let me put you out of your misery. Okay, so most people felt a 2-year-old with CD4 8%. I must say it's very unusual to get MAC in a young child. Very unusual to get MAC in a young child. So it's usually older children. Okay, and those who answered B would be quite correct. Okay, an older child with CD4 of 30 would be very prone to get MAC. Okay, because MAC is a true opportunistic infection, and it only really, you get disseminated disease in people who've got a low immunity, but you don't get in very young children. So 34 with a CD4 of 300 would be very unusual to get MAC. And the 4-year-old with 32 with CD4 of 32%, which is a normal CD4 count, also would be unusual to get. But certainly a 12-year-old with CD4 of 30, that would be your typical candidate for MAC, Mycobacterium avium intracellulare. So it is a complex of different mycobacteria. They are very, very ubiquitous. They are all over the show. It's in the soil, and obviously we walk in the soil and we carry it into our homes. So it's all over the show. Widely distributed in the environment. Disseminated infection is rare in very young children. And advanced disseminated infection occurs with advanced HIV disease. So in your adults over 6 years of age, it would be CD4 below 50. 2 to 6 years of age below 75. They do give counts for the youngest, but it's very unusual to get it in younger children. So just as in pneumocystis, our red flag is going to be the age of the child, between 3 to 6 months of age. So in MAC, our red flag is going to be the CD4 count. Okay, if the CD4 count is 300, you don't worry about MAC. If the CD4 count is 10, you worry about MAC. And why do you worry about MAC? Because if you don't think of MAC, it's like think bike, right? If you don't think MAC, you will miss the MAC. And not only will you miss the MAC, but you won't even be aware you've missed the MAC. Why am I saying that? Because if you have a patient with a CD4 count of 10 and they pass away, unfortunately, right? Are you going to say, whoops, I wonder what killed them? CD4 of 10, that's full-blown AIDS. We're not surprised they died. Okay, but yet they could have died of a treatable condition. So that's why you need to think MAC. If you have a low CD4 count, you want to think MAC. Look at the symptoms: recurrent fever, weight loss, failure to thrive, night sweats. We're talking about people with full-blown AIDS, fatigue, chronic diarrhea, malabsorption, recurrent abdominal pain, and respiratory symptoms are uncommon. These are common symptoms in certain people with full-blown AIDS. So you're not going to, there's no red flags here to say, think MAC. The only thing that's going to make you say, think MAC is the CD4 count. The signs, lymphadenopathy, hepatosplenomegaly. So none of those, I mean, those are all typical with HIV in children. The lab abnormalities, it's very unusual to get the pancytopenia that's discussed in the books, but they are all anemic, and they often will have leukopenia. But you're not surprised as a patient with a CD4 count of 15 that they're anemic. I mean, that's common in full-blown AIDS, and biochem is usually normal as well. So as I said, you need to think MAC, and what will make you think MAC? The low CD4 count. How do you diagnose it? You want to culture it from a sterile site. Blood, you can use ask the laboratory for the mycobacterial culture bottles. In my day, it was blue was aerobic, yellow was anaerobic, and red was mycobacterial. But you want to culture from a sterile site: blood, bone marrow, or lymph node. If you culture from sputum or from stool, all that tells you that the patient is colonized with MAC, colonized with MAC, but doesn't tell you they've got infection. You need to culture from a sterile site. And sensitivity testing is not helpful, except maybe perhaps for the macrolides. Treatment must include at least a new macrolide, azithromycin or clarithromycin, together with ethambutol, and some people do add in another drug, rifabutin, ciprofloxacin, or amikacin. In the old days, they used to say, I don't know if you're all aware, it's a very useful app or website called the Liverpool app. You can just go to the App Store and just search for Liverpool art chart or Liverpool drug interactions. And in the old days, if you check clarithromycin, it said don't use together with the ARVs. Why? Because if the PIs will increase your clarithromycin levels and the efavirenz will decrease your efavirenz levels. I don't know, we didn't have dolutegravir in those days, but I must say I've checked recently on the app and it says there's no interaction. So you can use either clarithromycin or azithromycin together with ethambutol. And we also, remember, these patients with a very low CD4 count, but you would want to wait 2 weeks just to try and avoid iris, because iris can be really severe. A couple of cases I've had of iris had severe abdominal pain. One patient presented with obstructive jaundice, and the mom cottoned on to the fact that all she had to do is go get steroids and the pain went away. So she went doctor hopping, because nobody wanted to put this child with a CD4 count of 10 on long courses of steroids, but she went doctor hopping. So it was very problematic, but very, very painful iris. Okay, those are the doses. I'm not going to go through them now. How long do we treat MAC? So in the old days, before ARVs were around, it was lifelong. You could not get rid of it. These days, they're saying if they're on stable heart, a minimum of 12 months, as long as the CD4 count is now above 100 cells per microliter in over 6, or above 200 in 2 to 6 years. But the problem is that if you've got a CD4 count of 10, right, after a year of ARVs, the CD4 count may not be above 100. So you might need to go longer than a year. Okay, let's talk about another very interesting disease. And there's an X-ray here. And so to have a look at this X-ray, I've just given you a CT scan as well. What is the most likely diagnosis in the 7-year-old child? I see I'm preaching to the converted. I'm going to stop the poll right now. Those of you who want to quickly answer, you're welcome to. Okay. All right. So you can see, what do we see on this X-ray? You can't see it that clearly on the X-ray. You can see lots of little dots around there, but on the CT scan, you see very nicely a typical miliary pattern. And so that's why a lot of you did say miliary tuberculosis, which is a possibility, but it's not the most likely diagnosis. The most likely diagnosis is number C, okay, lymphocytic interstitial pneumonitis, which the X-ray looks identical to that of miliary TB. The difference is that miliary TB tends to be in your younger children under 3 years of age, and your lymphocytic interstitial pneumonitis tends to be in your older children, your slow progressors. It's not absolute, you can get both at different ages. That's the typical presentation of LIP is usually your slow progressors, your older children. You may have clubbing the fingers, but you may not. They may have parotid-megaly. You get these lymphocytes deposited throughout the body, in the parotids, in the lymph nodes, hepatosplenomegaly as well, but they may not have that. They're often asymptomatic, but they can get dyspnea or cor pulmonale. X-ray looks identical to miliary TB, and with time it will disappear, or with ARVs. But the problem is that in my time, they said, just ignore it. It's a good prognostic sign because these are slow progressors, and just leave it. But the problem is they get recurrent bacterial chest infections, which causes lung damage, and they end up going on to chronic lung disease. So in fact, it was in the old days, LIP was a WHO stage 2 disease. So it means it didn't need to go into ARVs. And there was a South African delegation, I think it was under Professor Mark Cotton, who went to WHO and said, we need to move it to stage 3 because these children need to go into ARVs because they they're going on to chronic lung disease. In fact, it got changed to stage 2 disease, but in fact now, obviously, we don't wait for them to develop LRP. We treat all children with HIV straight away. Okay, so that's a typical X-ray as we showed earlier, and the CT scan. Obviously, you don't need to do CT scans, but people didn't know what was wrong in this child, so they did a CT scan. And the clubbing, typically mild clubbing on the fingers, but you can get clubbing, you may not get it. Okay, the management of LRP, major response to antiretrovirals. It literally melts within 3 months, it's gone. So you need ARVs. If the child is symptomatic, hypoxic, or core pulmonale, you can try a short course of steroids, but that's usually not necessary. Okay, then parotid-megaly. We said children with LRP can get parotid-megaly, so you'd always want to do a chest X-ray if you've got parotid-megaly. It's the same disease as LRP, usually older children, but this is proving that it's not always the case. Here's a baby, but this is a typical age, and they usually, with time they're looking like this, they've got cysts there as well, which you can pick up on ultrasound, very easy to pick up. They're usually bilateral, although one side may be bigger than the other. They're usually painless unless the cyst presses on a structure, when you can get pain. And as these cysts get bigger and smaller, so they may resolve and come back. And associated with LRP may or may not be, and once again, will get better with time with ARVs. In the old days, it was a dilemma whether to start these children on ARVs or not, because they were well children. These days, it's not a dilemma because they're all going to be on ARVs anyway. There is no confirmatory test for LRP. You could do a lung biopsy, but I don't think too many people would do it these days. The dilemma comes in whether it's TB or not. I think if the child is really sick and you're worried about TB, or you obviously want to try and prove it, then you would cover for TB. But if it's a typical, 7, 8-year-old walking around, it used to be like an accidental diagnosis. Granny had TB. They used to X-ray the children in the home and suddenly get this and panic and think the child had TB. And I had children refer to me from Sanka saying, please help. This child's been on TB treatment for 18 months and the miliary TB is not getting better. And we knew it wasn't miliary TB. We just put them onto ARVs and they got better. So yeah. To answer the question, there's no confirmatory test. If you're really worried, you could do a lung biopsy, but I don't think too many people would do a lung biopsy. They would rather just put the child into ARVs. And as we said, if it's untreated, they go on to chronic lung disease. This child with chronic lung, you can see there's dilated bronchus there. You can see it looks like some cysts there. When we did a CT scan, you can see the cysts demonstrated quite nicely. And that you don't really want to end up with this. That's why you want to treat these children with LRP when they present, when they diagnose with HIV, okay, and present and going on to chronic lung disease. These are typical clubbing of the fingers. In children with HIV, typically we see clubbing with chronic lung disease and with LRP. Those are the two main ones you see. The problem with chronic lung disease is that you've got a new diagnosis. You've got HIV, but it's an HIV caused it, but it's not just HIV. Once you've got it, you get this vicious cycle, and it's basically you can put them in ARVs and they'll still get recurrences of their chronic lung disease. So you need to certainly initially treat the lung disease as well. Home physio is the mainstay, that you need to get the physio to teach the family a home program. They can do it at home. You can nebulize them or give an inhaled beta agonist before physio to open up the lungs, get everything else, regular sputum culture, and then appropriate antibiotics if they do get exacerbations. HIV encephalopathy traditionally is a poor prognosis, but these days we'd hardly see it anymore. If I can just show you the slide here. This is what has happened to HIV encephalopathy as ARV treatment has come up. So as ARV treatment has come up, so HIV encephalopathy has dropped down. So we hardly see it, but there will be a few, as we say, a few cases who slip through the cracks. There's two main forms of HIV encephalopathy. There's static, which looks like cerebral palsy, and progressive is the same equivalent of AIDS dementia. So the child is developing normally and then starts deteriorating, losing the milestones. Okay, the progressive one, even in the old days, was extremely rare. The static one was also common. This is a child where you pick him up and his head flops back. You think it's a floppy child, low tone, but you put him in his tummy and his head still goes back. So it's not low tone, but actually extensor hypertone. It's increased tone in the extensor muscles of the neck. That's the first sign I found of encephalopathy. And after that, they go on to spastic quadriplegia. This child, you can see, he's grown nicely, but he's lying flat in bed because he can't sit. So here the ARVs have treated the HIV in the rest of his body, but not getting into his brain. Fortunately, we don't see much of that. Most of the time, we do see amazing results. They go from a spastic quadriplegia to a spastic diplegia. The brain recovers. This young child, we haven't got time now, but he wanted to show me one day that he could actually walk. He's at college at the moment. He's, I think, 22, 23 years of age now. He's at college studying, college doing very well. Yes, he's disabled, but his mind is good, and he's got a spastic diplegia. But what we do see, which is still very common, is learning and behavior problems. Okay. Was a meta-analysis looking at 8 studies, and they found ADD in 28%, which is 6-fold increased over the normal ratio. So although we don't see HIV encephalopathy anymore much, we are still seeing a lot of ADD. And, you know, it's all very well to say, well, you know, we'll treat the HIV and they'll live a normal life, which they do, but you don't want to end up with children becoming school dropouts. You need, from a holistic point of view, you need to treat their ADD. And I've found with my patients is that they will not tell us they've got school problems. They don't think it's our job until you ask. You need to ask, are they at school? What grade are they in? Have they ever failed? Are they struggling? And then unfortunately, all the gory details are going to come out, but you need to treat it. The big problem we have in the DOH is that you can treat HIV in a clinic, but you can't treat ADD because it's a Schedule 6 drug. So you've got to refer them to a hospital, which makes it more complicated. But from a holistic point of view of treating this child holistically, you do need to ask about school problems and to deal with it. Just to finish off, we're almost running out of time, with the tumors. Fortunately, cancers are very rare in children. I can count on my one hand the number of cases I've had. The common ones we used to see would be lymphomas, generally with the CD4 counts of low, would be low, and then Kaposi sarcoma. Kaposi, you don't see the typical skin lesions that you see with adults. They get what they call the lymphoglandular forms, where you get, I've seen malignant pleural effusion, mediastinal glands in the abdomen. These 2 children presented actually with Kaposi's iris. Okay, this child on the left, or this is one child, she presented with what I thought was a lipoma. CD4 was 200. She had a lump on her forehead. I thought it was a lipoma. Put her onto ARVs, and 2 weeks later, she was covered in tumor. There's one behind her ear. You can see femoral nodes there. There's one there as well. Just literally all over. This child, and that child actually did very well. She survived and did very well. This child, unfortunately, wasn't so lucky. She was put onto ARVs at a clinic. Started swelling up with massive nodes there. They told her it was TB, put her into TB. She didn't recover, and she was literally, you can see this tumor is just pushing the mediastinum right over, and she was literally strangled by this tumor. And this is the one iris where I actually stopped the ARVs, because it literally grows in front of you. I used to see this children in the morning. That evening, the tumor was bigger. So we stop the ARVs until they get the first dose of chemo, and then you put them back onto ARVs. Okay, but the one thing I found with all these children with Kaposi iris, if you look deep inside the palate, you'll see a typical purplish Kaposi lesion. So if you have a child with rapidly enlarging cervical lymph nodes, look deep inside the palate and see if you can see a purple lesion. And don't do an FNA of the nodes, because FNA will miss the vascular tumor. You need to have the tissue diagnosis, either do a biopsy of the lesion on the palate or a biopsy of the lymph node. Okay, we haven't got time to discuss iris, so I think we're going to leave it there. I did put the link on the chat for this poster. You're welcome to give us a call if you've got any patients, pediatric or adult. We've got an adult team as well that will helps out. That you want to discuss, you're welcome to give us a call. And any TB queries, you're welcome to give us a call on our Right to Care TB helpline. So thank you so much. I see there. I've tried to answer as many of the questions I could as we were going, but I see there are a couple of cases that we might need to discuss.
Yes. There was. Thank you very much, Dr. Leon. I think we'll take around 5, maximum 10 minutes just to go through some of the discussion points. That was quite comprehensive. Maybe before you go through the cases, you have went through a number of very important opportunistic infections in pediatrics. I just wanted to ask you, on a lighter note, how important is this topic today? Are we supposed to be still seeing these conditions in the context of large access to ARTs? And if we are still seeing these conditions, what were your understanding of the drivers for us to still continue to have babies in pediatric wards who are sick because of HIV?
Right. Yeah, it's a very, very good question. So the first thing is that even if our program was perfect, which, as you know, it's not, okay, we will still be seeing these patients. For example, I can tell you, I didn't have time. I didn't go through what used to be the commonest iris in children. One of the commonest iris in children was an enlarged axillary lymph node, right, and on the right. And what's the cause of that? Okay, BCG. Now, since we used to see it commonly, I'm sure you remember the old days. We hardly see that anymore. We hardly see that anymore because the SURE study showed that the children who went on the early arm, who went on to ARVs straight away, they did not get BCG iris. So we hardly see that. But yet I know that during COVID, when we had lockdown and people weren't coming to the clinics, so children weren't being diagnosed on time, okay, these cases were presenting again. Children were presenting with BCG iris. So they fall through the cracks. And if you don't know about these conditions, you're going to miss them. And also we do know in the real world, people get missed. People don't get linked to care, even if they are diagnosed, or you get adherence issues. They stop taking the treatment, the CD4 counts drop. So it's important that we are aware of these conditions, even though they're not, as I said in the beginning, they're not as common as they used to be. But, it's not a perfect world just yet. We're getting there, but not yet.
Yes. So yeah, thanks for that, Dr. Leon. Now, not necessarily on the Q&A, on the chat, around 1835, Masabata Motebe had a scenario of a 4-year-old child who was on treatment, actually diagnosed in 2019, never on treatment. I think the child was started on ARVs this year, but it's a very sick child. I would rather have Masabata call you on the call line because I see the viral load, it's very high. Beta-glucan is positive. The child has CMV, a pancytopenia, I think of around 7. The child was treated with for PCP.
Yeah, this is a really sick child.
Yeah, so I think you'll probably have more questions than answers yourself.
Yeah, and also I think we would need to go to the real ID guys as well. So we do it as a team effort. So maybe give us a call and we can address that one.
Great stuff, Dr. Leon. Now, whilst I look at the second case on the other side, then what are the possibilities to eliminate pediatric HIV? What does the future look like? Do you think it's probably a follow-up on the previous one? But what is happening out there? Is the future bright?
It's bright, but it's got dim patches and places. The thing is that if you look at our PNC program, it's been amazingly successful. Yes, we are hardly seeing. I mean, the positivity rate at birth is rock bottom. It's really low, but unfortunately, it doesn't stay low. It doesn't stay low, and they're largely driven by breastfeeding. Whether it's because mom's viral loads go up while they're breastfeeding, and they're no longer the baby's no longer on prophylaxis, or what may be more commonly is women who seroconvert during breastfeeding, and then obviously they seroconvert, it's new infection, their viral load is high, they're more likely to pass it to children. So we need to tick all those boxes. Yes, our PMC program is great. Okay, we can improve it for sure, but we're doing pretty well with birth positivity. But it's the later ones we need to address. We need to be monitoring those women, explaining to them. You should give as much education to a woman who's HIV negative as you do to an HIV positive, not in how to stay negative. Because if she is is negative and she's got a baby, that baby, and she seroconverts during breastfeeding or in pregnancy, that baby is high risk of getting HIV. So you want to educate our moms how to stay negative. We want to be testing, as we are doing in our new guidelines, we are testing breastfeeding moms frequently so that we make sure that those viral loads stay down, and if the viral loads are up, we want to do something about it. So there's a long way to go, but it's a question of ticking those boxes. Okay, we know where the problems are. We must deal with those problems.
Yes. And then now on LIP, I saw a number of questions, but I think they are linked. One was saying, how do you manage LIP when the underlying cause is a primary immune deficiency?
Yeah. I think obviously you need to go to an immunologist and need to sort out the immune problem. Steroids do have a that's the bottom line. What's causing it, right? What's the cause? You need to sort it. The steroids do have a role, but on the other hand, you don't want to be using steroids in a patient who's immune compromised for a long time. So short courses of steroids, fine, no problem. And we have used in the old days. Remember, I've been treating kids with HIV before we had ARVs around, and we used to use steroids, short courses, and they did work pretty well. Most children with LIP are actually asymptomatic. Okay, most are asymptomatic, but if they've had it long enough, they can develop cor pulmonale, and they can develop, shortness of breath, that kind of stuff. So those children, I found, I had a couple of kids who were, we had ARVs around, but they were in hospital, oxygen dependent. We couldn't get them out, waiting for the ARVs to work. So there we gave them short course of steroids just to get them sort of well enough to get home, and while we're waiting for the ARVs to work. But long-term, your management obviously is going to be management of their immune problem.
And then, Dr. Leon, you called LIP a true opportunistic infection. Tulisile wants to test an HIV negative child again because the child has paratidomegaly, maybe LIP. Does LIP occur in HIV negative kids? Does Tulisile need to continue to test the child again? What's your
so LIP was first described I think in the 1920s in children with leukemia. And then it sort of disappeared until the HIV came along. LIPs, we talk about LIP, but if you speak to a pulmonologist, there's three kinds of interstitial pneumonitis, right? This is what we call usual, UIP, DIP is desquamative, and LIP is lymphocytic. I think you're too young to remember fibrosing alveolitis, but we used to have patients in those days fibrosing alveolitis, and that was usually the usual UIP. Okay, LIP was very rare until HIV came along, and all of a sudden we started seeing it every second child. But I mean, paratomegaly is different. I mean, if you think paratomegaly, there are other causes, and you need to look into it. I mean, obviously, mumps would not be a chronic cause, although one of my patients had paratomegaly, and every time she got a new teacher, they used to send her home because they used to think she had mumps. But the difference is obviously mumps doesn't last all that long. But you need to do a workup. As far as I know, if child with a normal immunity, you wouldn't see you wouldn't see LIP. But I think certainly it being one of the interstitial pneumonitis, it probably can occur, but it wouldn't be very common.
Yeah, I saw a number of questions about pediatric regimens in the context of TB. I know that we want to have a follow-up session looking at the initiation and so on.
Cover it then.
Yeah, I think let's be patient, colleagues. That particular one, let's deal with it at the right time.
Yeah, I think if patients if they've got a patient with TB, they need to know about it now. So they're welcome to phone the helpline.
The helpline, yes.
Yeah.
No, that's perfect, Doc. So in terms of PCP, there was a number of questions. One wanted to understand how to diagnose CMV, which I think you addressed, the role of oxygen in the management of PCP.
Yeah, no, absolutely. I mean, look, these children, the severe children need to be in ICU, and of course they will have oxygen, absolutely. Some would require ventilation. I mean, it's and I'm not a specialist intensivist, so I'm not going to even attempt to address that. But certainly, oxygen would be part of your treatment. It's supportive treatment.
Great stuff. And then lastly, I think this is probably the last question, is around the prophylaxis therapies. Is it the same as adults? Should children be routinely screened for CREG? Should INH be routinely given? I think the scope is too large for this question, but maybe at a high level.
Just a few highlights of So CREG, you can certainly do it, but it's very unusual to see cryptococcal meningitis in children sort of under 10, 11 years of age. So it's very unusual. I think if we're doing lab is doing reflexy, they'll pick it up. But remember that CD4 counts are different, right? In children, CD4 counts, we'll do this in the next talk. CD4 counts are much higher. So you're not going to get a CD4 below, it's very unusual to see a CD4 below 100 in a child, even with severe immunodeficiency, because they're starting, in a child at birth. I mean, the CD4, normal CD4 count would be above 1500. You know what I'm saying? It drops with age. But so if they are doing it routinely and they pick it up, you would do something about it. But it's very unusual to see cryptococcal meningitis, in children who are sort of below 10 years of age. In terms of INH, I believe the guidelines are changing, but at the moment, the guidelines are that children would get INH prophylaxis only if they are confirmed contacts and under 5 years of age, or if they are HIV positive any age. So if it's an HIV patient who's a contact of TB, they would get INH prophylaxis, no matter what the age, but if they are HIV negative, then only under 5 years of age. I think it is, WHO is pushing to do it in all HIV kids like we do in adults. There's not good data, and that's why we haven't done it up to now, but I suspect that the guidelines are going to change when the new guidelines come out.
Superb. This was a very great presentation, Leon. It reminded me of I don't know, is it 10 years ago when these conditions used to be common, and you used to really give this talk. And I thought there's a number of people in this platform who want to write the diploma and so on. So I thought, no, let's bring Dr. Leon on board so that we are all empowered, especially around pediatric care. So really, this is quite appreciated. There's a number of questions around PMTCT and so on. I think we will deal with those questions at the right platform. I also want to appreciate, I saw some representatives from the National Department of Health, Ms. Leta, she's here, and then Nomsa from PMTCT. Thank you, for joining this webinar. Dr. Leon, your closing remarks, and maybe as a Minister of Health, what do you want us to be doing from tomorrow?
No. That I'll leave to you, Lesego. That I'll leave to you. Just to comment on the PMTCT, I think you need to address it, and you need to look at it, the private sector versus the DOH sector. Okay, and the difference here is breastfeeding. Remember, in the private sector, they're pushing not to breastfeed. Okay, and DOH we're pushing to breastfeed. And AZT is good for prophylaxis if they're not breastfeeding. It's not good for breast milk transmission. So if the mom is breastfeeding, they should get nevirapine at least, plus obviously maybe even additional AZT. If they're private sector and they're not breastfeeding, or even the government sector they're not breastfeeding, they can get AZT. But there's a lot of confusion over that. So when you get someone to deal with the PMTCT, it won't be me because that's not my field of expertise. But you need to take that into account, because it's caused a lot of confusion, especially in the private sector, where people don't know, should they use nevirapine, or they'll be breastfeeding and use AZT. So that does cause a bit of confusion. But just to say that, yes, these conditions are less common now. Fortunately, I'm very thankful they're less common. We hardly see them. When I revived this talk last year, I had to go back and do my research because we're not seeing them as commonly. I had to go check up on do all these things, treatments, are they still the same? And I did check them up. And it's great. I'm very happy that we're not seeing them and that it's not so important. But I just think it's important, as you say, to be aware of them, because these children do slip through the cracks. Children present, who moms were negative at birth, present at 10 years of age with low CD4 counts, with some of these conditions. So just to be aware of these things. At the back of your mind, hopefully you'll see a child say, I remember Leon spoke about that. And you'll phone the helpline and we'll help you with pleasure.
No, great stuff, Dr. Leon. I think that is